Hi, the following content is for educational purposes only and does not constitute medical advice. If you are a healthcare provider, please consult with your affiliated institution or local ethics committee for ethical guidance related to clinical practice.
Okay, Module 12, take 2.
Okay, this is David Magnus. Today we're talking about precision medicine or precision health research. First, just a disclosure, all the views I'm going to be expressing here are either my views or summaries of views of others in the literature, but they in no way reflect necessarily the views of the All of Us Research Program or NIH. And I say that because my disclosure is that I'm the co-chair of the IRB for the All of Us Research Program. And Russ says he has no disclosures to make, correct?
That's true. I'm just a fan of precision medicine.
Okay. So, and a professional actually, but
And a
yes.
professional precision physician.
Yeah, there we go. First distinction that's really important is the distinction between precision medicine or precision health research as opposed to precision health delivery of care. And so I think that's just important to keep in mind. These videos, we're just going to be talking about the research aspects of this, which are really probably of most interest to those of you who are bioengineers. But one of the articles that you've got for today is about the ready for prime time problem and when is it ready to transition from research into clinical practice and the problems and challenges with that transition, which is I think it's a very nice and important article and important topic, but we're really going to be talking just about some of the research ethics issues that arise. The first thing I want to talk about just briefly, and one of the articles talks about the All of Us Research Program, which is part of the Precision Medicine Initiative that was started by President Obama, had bipartisan support in the 21st Century Cures Act, continues with bipartisan support, and so it's a very well-funded effort with very little opposition. And the idea is to bring in 1 million people and to have a diverse group, which is their goal, that represents the diversity of the country, of people who live here or reside here, and to include samples from them so they can do full sequencing of over 1 million people, which is pretty amazing, as well as access to their electronic health records, surveys that they fill out, physical measurements that are taken, and for at least a portion of them, wearables like our Apple Watches and so on, so that they'll have all of this incredible database that's available for researchers. Although this is a very, very big, and if it's completed, will be one of the largest, most diverse databases, there are many others. There's something called the Million Vet Program at the VA that's bringing together a huge amount of information from the veterans to the Veterans Program. There's the UK 100,000 Genome Project, which is going to be more than 100,000 genomes sequenced when all is said and done. China is probably going to
actually the UK Biobank is 500K.
500K. So, and how far along are they in that?
They have genotypes, that is to say, not the full sequence, but genotypes for all 500,000. And they recently released about 50 or 60,000 exomes for a subset. So it's getting to be a very serious resource.
Okay, so that's a great resource. China is spending amounts of money on this, at least they were before this current crisis, that potentially could dwarf all of these efforts. They had announced plans to spend $9 billion on precision health research efforts. And then in addition, there are smaller local efforts, often by health systems. So we have our own efforts here at Stanford. Kaiser has a mid-sized one. There's a health system in Pennsylvania that has a really nice big database called Geisinger Health in Pennsylvania, and there are a number of other local efforts. So first question is, why do this? Why have precision health research, and why do it at all? So part of the reason is just the recognition that all physicians are aware of the fact that when they give medications, some patients do better than others on the same medication. There are differences in side effect profiles. There are a limited number of variables that physicians can take into account in making their judgments, which is partly why it happens that way. There's the limited amount of data that's really going into the judgments about what people should be using. And the goal is to try and figure out ways of getting better predictions about who's going to benefit from different things, and to do more, get our cohorts much narrower, so that we're less likely to have medicines and interventions that don't work, and more likely to have interventions that do. Just to give an example of some research that's going on at Johns Hopkins and at Stanford as well, and probably other places. When a patient presents for palliative radiation, so they've got a really bad tumor that's incurable, and they present for palliative radiation, physicians in their heads bin those patients into three groups: patients who have just a few months to live and are going to die no matter what they do, and whom radiation just makes the end of their life unpleasant and does no benefit to them; patients who might live a bit longer and who would benefit from at least a little modest dose of radiation, but you wouldn't want to give them too much because they're only going to live a matter of months; and then patients who actually, if you give them a reasonable dose of radiation, they're going to be sick for a while, but they actually could live for a few years. And so you're actually buying them some significant time by giving it to them. And so physicians sort of create bins in their head about what the prognosis is for patients, about how long they're likely to live if you do or don't give them radiation. The problem is when you actually do surveys of physicians and their judgment and then retrospectively look at the outcomes, physicians are terrible at making those predictions. But if you have a huge amount of data, and right now that's being done without a lot of genomic data, but in the future it can become even more precise with genomic data. But even just using electronic health record data and really looking at thousands and thousands of variables that can be done by artificial intelligence, which we'll be talking about later in the course, and analyzing it, it can actually do a much better job of putting people in the appropriate bin and giving better guidance. So the idea is that way you could, be more predictive about who's going to benefit from WIT and get your radiation titrated, so that rather than treating all patients either guessing, which is what happens a lot now, or alternatively just treating everybody the same, which a lot of physicians do, which is let's just give everybody a lot of radiation, even though it means a lot of these patients are going to suffer needlessly at the end of their life. Instead of doing either of those things, let's actually see if we can cohort people appropriately and give them the appropriate care.
And this is a great example of why it's called precision medicine, because you use all this data to make a more precise, more accurate assessment of the patient and what's likely to help them. There's a sense that we do okay, but most patients are currently treated as a one-size-fits-all. And the idea here is precision in the diagnosis and then precision in the treatment.
Right. So, how do we do the research to make that kind of shift in clinical practice possible? And there are two primary data sources, right? So the one that we're not going to talk about today involves secondary uses of clinical or public health data. And we did talk a little bit about some of that when we talked about the issues earlier in one of the videos about the uses of blood spots left over from newborn genetic screening. So that would be an example of a public health database, and researchers who use that would be making, I like the red, that's very nice.
Thank you. I'm trying to bring in more color, literally, to my notes.
That's great. So, so that would be an example of a public health repository and secondary uses of de-identified, or we talked about some of the problems with calling it de-identified with that data. A lot of healthcare systems make their electronic health records data available, test results, images, lots and lots of data that hospitals have. Our electronic health records are full of huge, huge quantities of data that potentially could be sources of some of this research. So that is one source, but we're not going to be talking about that today. Today, what we're going to really be focused on is when you really think about precision health research initiatives, are really the intentional creation of very large repositories, research repositories, or modest sized ones. So Geisinger, Kaiser, where they have electronic health records, but they're specifically getting consent from people to be part of these research efforts and getting samples of them to be analyzed for research purposes. And whether that's Geisinger or Kaiser or Stanford as a health system, or nationwide in this huge effort to recruit 1 million people. Any of you students who want to join, you get $25 if you fully participate. Not
How
going to
much?
say that it's a good thing. They get $25 for being full participants.
In all of us or Stanford?
In all of us, in
Okay.
the All of Us research program at NIH, they get a $25 gift card. I don't know if that's I don't know if that's worth it, but that's and the trade-offs. And we'll talk a little about some of those. Typically, in these kinds of efforts, where you actually are creating explicitly a research repository, usually some kind of consent is obtained as the samples are collected for these research activities, as well as permission and a waiver of HIPAA authorization to access electronic health record data. And all those things are at least mentioned or covered somewhat in consents that people sign in order to be able to make these repositories take place.
I'm just going to note that EMR, electronic medical record, that's the abbreviation I'm using, also sometimes called electronic health record. So EHR, EMR will both appear in the literature.
Yeah, I usually say EHR, but it's I go back and forth.
Yeah.
The first problem I want to talk about, and this is going to be the subject of this video, is really the justice problem, which is the unbearable whiteness of data. Right now, our populations for these kinds of research repositories tend to be white, middle class, or affluent, well educated. They tend to be very biased populations. And the worry that everybody has is that if some populations are systematically underrepresented in studies, then all of our predictions and cohorting to provide better care are going to result in the predictions that will not obtain to many of those populations and will lead to potentially inaccurate treatments or no cohorting at all for large parts of the country. So if you're part of a racial or ethnic minority, if you're part of an economically underprivileged population, potentially some gender minorities, all of the predictions of what really matters for your health really won't obtain. So I think all of those things matter: racial diversity, ethnic diversity, gender diversity, rural populations are underrepresented, socioeconomic diversity. And I will just say socioeconomic diversity may be as hard or harder even than racial and ethnic diversity, and particularly illiterate populations, which I think are going to be very, very hard to be able to recruit from. So that's really the challenge. We'll talk about some successes maybe in a little bit, but I will say that some colleagues and I carried out a bunch of research in which we were looking at these kinds of questions to try and figure out, get a better handle. Other groups have done similar work to try and understand what it is that's going on and why it's so hard to recruit from some of these populations. So we partnered with the Palo Alto Medical Foundation and Sutter Health to create a group of focus groups. So we had 20 focus groups with people from non-Hispanic white populations. We included 4 of those. We also had 4 African-American focus groups, 4 Chinese-American focus groups, 2 in English, 2 in Mandarin, 4 Hispanic Latinx populations, 2 in English, 2 in Spanish, and 4 South Asian populations, all conducted in English. So a total of 122 participants across these things, and we analyzed them as a group as a fairly large research group that included not just researchers at the Center for Biomedical Ethics, but also partners with people at the Palo Alto Medical Foundation and some partners at Seattle Children's Health's bioethics program there. So we published several papers out of this. The first one, which was kind of an interesting set of findings, was around, and it fit very well with other research that I've been doing in linguistics involving physician-patient communication. And that's really the importance of metaphors and the metaphors we look at. So when we call these things biobanks, which people do all the time, where does that language even come from? So the notion of using a commercial metaphor like a bank to describe organs or tissues or blood actually came out of the notion of a blood bank, which was created in the 1930s and Chicago, when they were first doing research to try and understand better how to preserve blood so that it could be used clinically later on. And they were doing a lot of research to really understand that, and then also to make that available clinically. So at Cook County Hospital in Chicago, they were really the leaders in this. And Bernard Fantis was trying to get people to donate blood for their Cook County Hospital blood preservation laboratory. And they were having trouble getting people to sign up for the blood preservation laboratory. And so in 1937, they called it the blood bank, thinking that that might make it more palatable. And in fact, it worked. And now it's become quite ingrained that we use often commercial metaphors like banking metaphors, and we talk about cryobanks and tissue banks and all kinds of things. But one of the things that we found is that different populations respond very differently to some of those commercial metaphors. Moreover, and we'll come to this in just a little bit in another article we published, it really emphasizes certain aspects of the process of building a research repository over others. It really emphasizes the samples, the biological samples. When you call it a biobank, it's really emphasizing that and de-emphasizing the electronic health record data and all the other data. Whereas if you call it a database, which is what some repositories call themselves, that emphasizes the data and de-emphasizes the samples and the sample aspects of it. We actually constructed our own metaphor that we thought people might find useful, which is the library metaphor. We thought this was a metaphor that worked pretty well in a lot of ways because it stores information for the public good. People make volunteer things to this public good, but once you donate it, it belongs a book to the library, it belongs to the library, and librarians control access to the library. So we thought this was actually a pretty good metaphor, and we tested it, and it looks like it had some benefits over most of the existing metaphors. We called it the Library of Medical Information. So that's something that we're recommending that researchers do. And you'll see why that might matter in just a minute. But one concern that we have is that the unintentional use of language may convey things unintentionally that turn people off. And I'll just say that this is a ubiquitous feature of language. We often convey much more than we literally say. Russ, do you know what time it is?
It is how long we've been into it.
No, you don't have to answer the question. That was just to make my point. I asked you a question, the literal answer of which was yes or no, because I asked if you know what time it is. And instead of answering my literal question, you actually tried to tell me what the time is and figure out what I wanted to do, which kind of makes my point. This is a ubiquitous feature of language and communication that people try and figure out what the intention is behind the literal utterances that are made. This is especially true for metaphors, which are not literally ever true. When I say my love is a rose, I'm not saying that I'm married, I have an unhealthy married relationship to a plant. And so we have different intentions behind it, and we make guesses about what those intentions are. But the bigger the gap between researchers and participants, the more likely it is that the language that people use may lead people to make false inferences, which may undermine trust. And so that's kind of the lesson of the kind of thing that we're trying to do in that.
You do that to me every year, and every year I forget and just fall into your trap. It's very irritating.
Sorry. I thought this time you were going to remember, but I happy. At this point, do you know what time it is? It's become pretty much idiomatic. So arguably, it's almost not even an indirect speech act, but it's part of the semantics. But I digress.
It's not really a yes/no question anymore.
Yeah, I think that's right. So in another paper that we published together that I love the title of, called, it's a quote from one of the focus groups from one of the participants called, "I don't want to be Henrietta Lacks." One of the things we looked at was, do people look at data versus samples the same or different between all these different focus groups? And so we asked them how would they feel about their electronic health record data being used, and then how would they feel about their biological samples being used for research. Many people saw them as very similar and pretty much the same. In every focus group, there were people who, except one, there were people who expressed that they're pretty much the same and they didn't see them different. However, there were many other responses that were different, and interestingly, those differences really varied across the different racial and ethnic groups. So the non-Hispanic white groups were not as concerned about this, but the other groups were, many of the other groups were concerned about ways in which samples are an extension of the self, and therefore require special care and respect. And the non-Hispanic whites did not care, but the other populations expressed anxiety and worries about somebody cloning them, which suggested a broader level of mistrust of researchers. In contrast, non-Hispanic whites expressed more concern about economic justice and about their potentially losing out on a share of potential profits to be made from their sample donations. So we saw very differences in response. Everybody, all the groups worried about privacy, and we saw that in all the groups. And so they all had that in common. But some of these other things, really, we saw these differences. And the reason why that relates back to our metaphor work is if you use a metaphor that emphasizes the sample aspect of it, and we know that racial and ethnic minorities might be more likely to be more concerned about samples than about data, then it means that those metaphors may not resonate as well with those populations and resonate more with non-Hispanic whites. Whereas if you use a metaphor that emphasizes the data aspects, that might actually do better with some of those populations. And then I just want to say one last piece of research that we did coming out of that was really more directly about how they looked at this research and how much trust they had in them. And we really found four main themes in the data that we had. First of all, there was tremendous differences in expectations of benefits, of direct benefit, in which non-Hispanic whites thought this was a great thing and precision medicine would definitely be beneficial to them. But there was a lot more skepticism of that in our other populations. Second, we saw a large amount of fear of population profiling expressed by some of those populations. Third, as for the Chinese and Hispanic populations, especially for the ones that were not conducted in English, there was a general unfamiliarity with the American healthcare system, which created challenges for them in thinking about engaging in research. And then all of the non-Hispanic white populations all expressed very clearly the importance of engagement and recognition of cultural differences to create a trustworthy enterprise. And I think one of the things that came across more than anything is that for this research to be successful, it's going to be critical that a trusting relationship be established. And to have a valid basis for a trusting relationship, it's going to be really, really important that researchers not just are perceived as, but actually are trustworthy stewards of information, data, and samples that are entrusted to them in order to be able to carry out research that will be of benefit to broad populations. I think we are seeing similar issues play out now as the COVID virus is differentially impacting different populations, and people are worried and anxious about which populations are likely to be included in clinical trials, and whether or not the success and who's going to get tested and other sorts of things, are the goods going to be equitably distributed and so on. So clearly creating a more trustworthy enterprise in which we establish a better track record of being more equitable is going to be important for this research to be successful. Okay, so that's really the big justice issue. I want to end with one positive note, which is the All of Us research program, which to date has several 100,000 participants who have signed up and turned over samples and consented to uses of their electronic health records, is stunningly diverse and unlike every other large database that's in existence. And I don't know much about the racial and ethnic makeup of the UK biobank.
It is exactly what you would expect. It is 95% Northern European whites from England and UK, Scotland, and Northern Ireland and Wales. And in fact, there's a very small number of underrepresented minorities with African and Asian ancestry is so small that it's almost like you can't do anything with it. So there's a huge need for filling in those gaps.
Well, so of the first few 100,000 people in the All of Us, or maybe it's maybe getting close to 400,000 or 500,000 in the All of Us program, they're running at about 18% African American, about 17% Hispanic Latinx. They have a very significant rural population. They have their socioeconomic diversity is pretty good. Their education diversity is not terrible, but it's not as good. But you hit all these different populations. The Asian population is representative of the population. So if you look at all the different targeted populations that are underrepresented in research, right now it's something like 60% of the participants in the program are from those populations. So off to a good start, and we'll see if they're able to maintain this as the program continues to go forward.
And
And
it
that's,
occurs to me I have one disclosure, which is that I'm on the International Advisory Board for the UK Biobank. So I should have thought of that.
yes, that's a good one to
There's
disclose.
your disclosure from Russ. Okay,
Okay,
this
there
ends
we go.
module 12.
Yep.
Thanks. See you at the next one.